last 15 years, I've been presenting these kind of things. Usually, we have line যখন আমি বলি বাংলাতেই বলি, আমরা ইংলিশে ঘরোয়া পরিবেশে বলি. So it's a very good idea to present this kind of topic, and it's a very brilliant idea to choose this topic on the eve of World Health Day actually. So kidney disease, by kidney disease we are preferentially will be discussing about the chronic kidney disease that is coming in as an epidemic threshold of non-communicable diseases. We've heard of epidemics about COVID, epidemics about influenza, epidemics about diarrheal illnesses. Now we are bothered about epidemic of non-communicable diseases, and one of them is chronic kidney disease. So in summary, the present and future impact of the kidney disease is a tsunami. So what you're expecting in this time and in near future is a tsunami. And why is it so? I'll be describing you in my next slides. So 700 million is the number of people who are suffering from chronic kidney disease worldwide. And this is only chronic kidney disease. If you take into account acute kidney injuries, acute renal failures, and patients who are already transplanted and having some kidney dysfunction, the value goes up to 850 million worldwide, which is a huge impact on the health system on any country. I'll be discussing the different rates and differential distribution of these things in developing and developed countries, which has a definite trend that we can understand. Speaking about the data that we need to know, that kidney disease prevalence is increasing globally, and it is now the 7th leading risk factor for mortality worldwide. Can you name the first cause of death, mortality worldwide? First cause of death. Anybody? Coronary artery disease is the first cause of the death. But kidney disease used to be unrecognized as a cause of death even 2 decades back. It was positioned as 15th or 16th in number, and now in last 20 years to come as the 7th highest cause of death in worldwide scenario. The global prevalence is 10%. Compared with it with diabetes. The global prevalence of diabetes is around 10.5%. It's close and is exceeding diabetes. So two most prevalent chronic diseases that we are going to treat in the next 3 or 4 decades or decades coming after that is diabetes and chronic kidney disease, which is due to diabetes or even without diabetes. So the cause of this epidemic is increase in diabetes, hypertension, obesity, and adverse lifestyle changing contributing to the facts. The burden of the kidney disease again, unfortunately, is highest among the historically disadvantaged population that often has limited access to optimal health care. Poor country beshi hoy, which leads to the statistics of 1/3 of the kidney patients of world live in China and India. So this is the map of kidney disease, chronic kidney disease that is being in worldwide. It was a data presented around 2015. You can see there's no data of India because Indian data collection for CKD is very poor. This was a map when presented, it was around 2015. But what you can see is this map where they are showing number of dialysis centers as compared to the many other countries around the world. India has the lowest number of dialysis centers considering its huge population and huge burden of chronic kidney disease that we know that we harbor in this country. Now the recent data are coming about the chronic kidney disease prevalence in India. The recent data published by Jitmar Pondicherry about a cross-sectional study that showed the prevalence from different areas of India shows that the prevalence of chronic kidney disease is from as low as 8.6% in eastern zone to as high as 15.3%. There will be statistical and reporting biases because you understand that maybe from our centers there will be under-reporting of the chronic kidney disease centers as from the western zone or southern zone, which reports chronic kidney disease in a much better style. So India has a prevalence of chronic kidney disease which is even higher than the global average of 10%. So what happens to a person who develops chronic kidney disease? with an early stage of 21 years. In this study, they have showed that from the beginning of the diagnosis of chronic kidney disease, the patient start developing decreased survival. And as the age increases, the difference between the survival decreases from somebody who does not have a chronic kidney disease. So the highest impact of this disease is from the population of 21 to 45 years, where the normal population who doesn't have a chronic kidney disease will continue to live in a straight line without decreasing survival, but can see the early decrease in survival even as early as the age of 21 to 35 years. So it's a devastating disease to have even in a young patient. So this is how the chronic kidney disease behaves. If somebody develops a chronic kidney disease, we'll consider it on type 1 diabetes. The blue line is for normal albuminic patient. The green one, the deep blue one, is for somebody with microalbuminuria, and the red one from somebody having a macroalbuminuria. You can see the steady and relentless decrease in eGFR along with time. CKD is a progressive disease. The glomerular filtration rate will decrease with time in whatever amount of treatment you can give. So eventually, if you are not preventing it, almost all the patients, if they live longer, will develop into a stage 5 chronic kidney disease and will eventually require dialysis. So what is the difference? What is the rate of difference of somebody who is developing a chronic kidney disease versus who do not have CKD? For somebody who is in the age range of 21 to 35 years, developing a chronic kidney disease means he has a 5 times more chance of dying in next 10 years. The amount becomes, the magnitude becomes lesser in elderly population who already develop some amount of comorbidities. For a younger population, the consequence of developing, the impact of developing a chronic kidney disease on individual level is catastrophic. But chronic kidney disease per se does not come alone. It comes with other most disadvantageous diseases. Chronic kidney disease is a risk factor for coronary artery disease and a major risk factor for heart failure. In this diagram, you can easily see that somebody who is having a GFR of less than 60 versus a GFR of more than 60, how much is the difference of major cardiovascular events for somebody who is having chronic kidney disease as compared to not? Huge difference in major cardiovascular disease. So there is a mortality due to the chronic kidney disease, added or multiplied mortality due to the addition of high risk factors of coronary artery disease and cardiovascular disease. This chart depicts it in even viciously. The upper line is for the dialysis patients and lower line for somebody who is not even on dialysis and on normal and slightly higher GFR. You can see the mortality, an annual mortality, almost 500 to 1,000 times more for a coronary artery disease for somebody who is already taking dialysis, for somebody with an age-matched population who is not taking dialysis. So the impact of chronic kidney disease on mortality is catastrophic due to itself a danger of chronic kidney disease, relentless progression, requiring dialysis, development of coronary artery disease, increase in incidence of heart failure, and increased mortality. So the burden of the chronic kidney disease can be numbered up to premature mortality, disability, cannot work, cannot go to office or loses his job, reduced quality of life, of course, with amount of so many pills, so many fluid restriction, so much of food restriction, reduced quality of life, psychosocial harm, it goes into depression, high cost to government and healthcare system. The chronic kidney is a huge burden, high cost to the individuals and families in part because of the lost productivity. Such is the huge impact of chronic kidney disease on even outside the medical side we are discussing. So if the burden of a chronic disease is in preventive medicine, we have read about this, is discussed with DALY, disability adjusted life years. It means the number of years a person would have survived without the disease. Now he has the disease, so how many years lived with disability and years life lost because of the premature death. This plus this is the measurement of DALY. It is the marker of the burden of the chronic disease, any chronic disease in worldwide population. Now if we can see the huge burden of DALY in chronic kidney disease, you can see the map. This is a disabling situation.
And you can see India, the DALY is just better than few more countries like the Panama and southern part of America and few areas in Pacific Ocean and Indonesia. India's situation is as bad as most part of the Africa. We have a huge DALY due to the chronic kidney disease. So is the burden of the disease. Now, if you compare the DALY due to the chronic kidney disease as well as the cardiovascular disease, you can see that Southeast Asia ranks almost 4 or 5 among the top countries which have a highest burden of DALY because of chronic kidney disease and associated coronary artery disease. The impact is huge. So what will change? Will it change in a better manner, in projected for the next 20, 30 years, or it worsen, continue to worsen? It will continue to worsen. So if we see what will happen in the next 20 or 30 years, you can understand this is the annual change of death rate percentage in worldwide due to chronic kidney disease. So every year the death rate increases by in India by around 2%. Which you can calculate in the next 20 years will increase by almost 40% if you do not intervene, and almost a huge number of impact on the healthcare system. Similarly, annual change in the years of life lost due to CKD, annually it's more than 3% in India that it changes. So in next 20 to 30 years, your general population base will be mostly chronic kidney disease. Whoever you see will have a high creatinine and chronic kidney disease and associated coronary artery disease. Such is the impact of the coming tsunami of chronic kidney disease. So India has almost 145 crores population at this date. So at 2% of the 145 crores population means almost like 3 crore population of India in next 10 years will be having any form of chronic kidney disease. The burden is unimaginable. So it's more than diabetes, it's more than tuberculosis, it's more than COVID. So comparing with other chronic disease that we are discussing, number one, the coronary artery disease and stroke, you can see this very interesting chart that compared from 2016 and projected to 2040, you can see the year lost life due to coronary artery disease decreases, stroke decreases, only diabetes and CKD continue to increase, and chronic kidney disease is almost surpassing diabetes. So by 2040, the only disease which will be increasing day by day with relentless progression will be chronic kidney disease. With specific protection, you can see that heart disease and cancer are going to reduce in 2040, but that is not the scenario in case of chronic kidney disease. So the future impact that we are expecting is none less than a tsunami that I have shown. What is the present expenditure? You can see that in this cartoon, that India already spends around 25 to 50 billion rupees in care of chronic kidney disease. And you can understand in present absence of major government-driven insurance policy in India, most of the expenditure comes from the pocket of the patient. And we understand that most of the patients in India, 90% of the patients of the India, dialysis is driven by the cost of the dialysis is driven from the pockets of the individual patient. So if you want to convert this amount of expenditure from the government health budget, the amount is extremely high. So this is the comparative expenditure in chronic kidney disease and dialysis as compared to other countries of Southeast Asia. It's much worse than China and worse than Japan. India and Thailand are probably the highest who are spending and going to spend the amount of money, the proportion of the annual health budget in the treatment of chronic kidney disease, including dialysis. Such is the economic impact that is going to come to chronic kidney disease in the near future. What happens to developed countries? In this impact CKD report, which reports the impact of chronic kidney disease in the UK, the most interesting thing, they have published in the results is a 7.7% increase in CKD population by 2032 was predicted, with increasing numbers of patients with CKD stage 3 to 5, 21.7%, dialysis patients 75.3% increase, and transplantation almost 60% increase. The increase of the patients on renal replacement therapy results in an increase of 75% across fresh water use. What is the effect on the environment? Fossil fuel depletion and carbon dioxide emission over the next decades, and an estimated cost of 1.95 billion pounds in case of a small country like United Kingdom. And you can project this value to a much higher prevalence and to a much larger population base in a country like India, and understand what catastrophe is going to come to India in recent times. In a different note, somebody who is planning to start dialysis center, for them it's a win-win situation. By 2022, the dialysis market is going to be 236 billion, and the majority of it will be the Southeast Asia and India. So, extremely high number of patients with kidney disease is going to come. Associated increase in the cardiovascular diseases, including heart failure. India and China are going to be the global capital of chronic kidney disease. The economic impact if this trend continues will be lasting on everybody. And probably India will look like something like this in 2040. Everywhere there will be dialysis centers and nothing else. All hospitals will probably be converted into dialysis centers. So such is the impact. But I will definitely say, I'll finish my talk, that there must be a chapter 2 where I must be talking to you in another day, another time, about how to prevent that. There will be strategies, there are strategies that are being discussed so that this green situation, this tsunami can be handled. I'll finish my presentation at this. Thank you.
Thank you, Dr. Sengupta. You have very nicely explained the current modalities of CKD. I would like to say one important thing. I think you rightly explained, it's progressive, it's degenerative, and it causes irreversible damages. And finally, we have to concentrate to prevent or delay the complications. The two factors of mental specifically, one is the heart failure, and other is the diabetes, although other more complicated diseases are also there. Regarding the heart failure, we people are very much depending on how 40 years of treatment along with the army. It is the same, EGFR up to 30 we can use this. And beyond that period, we are not to consider medicine or something like that. What is the opinion regarding the CKD cases of heart failure using what's in heart failure drugs like a medicine, but beyond that, in the ancient therapy also. And another case of diabetes, I would like to say that as because in 1 in every 3 cases, we are finding the patient with diabetes when CKD, and we are basically depending on albuminuria, we are macro, we are basically depending on EGFR, that's statin C. My question is that if it is very much progressive, or in initial stage of diabetes, what is the opinion regarding initiation and optimizing the doses of insulin in early stages than the beyond that? All the campaign directed medical therapy significantly so starting the dose of oral anti-diabetic drug. And many nephrologists, your opinion regarding initiation of insulin, keeping in mind the complication of CKD is early as possible.
See, there is no hard and fast guideline about that. Whenever you develop CKD, you need to start insulin. Insulin is entirely need-based. We need to understand that the myth of that the higher creatinine will hypoglycemia may not be true in Indian population. Many advanced CKDs will have extremely uncontrolled sugar, and the major drugs to control blood sugar in CKD we cannot use, namely metformin we cannot use. Sulfonylureas become less effective with more chances of hypoglycemia. Pioglitazone, less than 30 GFR we cannot use. So the choice of oral drugs becomes limited. For us, efficacy point of view, this DPP-4 inhibitors, I don't think they're a very good choice for controlling a very high blood sugar with a high HbA1c and CKD. So what remains to us, even the SGLT2 inhibitors are not very good drug to control a high HbA1c. So what remains to us in an advanced CKD with a high HbA1c is the administration of the insulin. You have to be careful about the dose of the insulin because the eating pattern and the appetite of the patient is unpredictable and low as compared to a general population. So you need to be very cautious with more frequent monitoring and more frequent sugar check and OPD visits regarding adjustment of the dose. You might have to ask the patient to almost on the daily basis in the initial stages to check their blood sugars and report back to you so you can adjust, give micro adjustments in the sugar to avoid hypoglycemia. That would be, I was saying, on insulin therapy.
Any question? Okay.
How do you test finerenone and SGLT2 inhibitor?
So finerenone, as of now, as we know, finerenone is a non-steroidal mineralocorticoid antagonist. Finerenone is, as of now, is approved only for diabetic CKD and is being very commonly used in diabetic CKD. The main effect of finerenone is on proteinuria rather than on eGFR. We have seen in our clinical experience that the drastic reduction of proteinuria happens with finerenone, but you have to remember finerenone therapy is given over and above a standard therapy of AC inhibitor or ARB. The patient has to be on a maximally tolerated dose of AC inhibitor and ARB. Then we start finerenone. In my clinical practice, the common mistake, the prescribing mistake that I commonly encounter with finerenone is that straight away a diabetic patient is being started on finerenone without giving trial to AC and ARB. This is a wrong practice. We have to give an ARB, telmisartan or valsartan or whatever, and losartan, and then as per maximally tolerated dose, if the proteinuria continues, you add on finerenone for the kidney indication. Now, as for non-diabetic CKD, even in my centers, I am a principal investigator of a trial which is evaluating the effect of finerenone on non-diabetic CKD. The trial will be over by 2026, and probably the result will be published by 2026 mid, and we'll get to know what is the effect of non-diabetic CKD as finerenone is going to decrease proteinuria and creatinine or not.
Thank you. One.
No, you cannot start. It is not recommended.
Finally, I would like to end on question regarding use of insulin. GLP-1 exists in a time when I'm giving it this one. Starting it goes like GLP-1 from 40 to 58. So what is your opinion? Not only I'm soluble insulin, I'm saying not saying about creatine 100 or 300 per liter or blue acid. I'm considering it for exists in a time. GLP-1. Does it give any harm to the problem of reservation regarding
The GLP-1 receptors are the receptor analogs are coming in a very large way in chronic kidney disease. It's the benefit, the amount of benefit, specifically on proteinuria, is almost as good as SGLT2 inhibitors. So the actual the pipeline of the therapy, the algorithm of the therapy, where HbA1c is well controlled, is the must to start with an SGLT2 inhibitors. And if you AC inhibitors and ARB, the proteinuria is higher. If you start finerenone, if the sugar is not so much controlled, instead and cannot give metformin because of the GFR criteria, I think it is the most important to start with GLP-1 receptor analog. The only difficulty in our country is still the high cost. In Western countries where it's been government insurance given, GLP-1 analog, receptor analog is given, it's rampant to use GLP-1 RA just after the use of DPP-4 and SGLT2 inhibitors.
We are very much shortage of time, so I think we should call it a day immediately.
Hello, I am Dr. Mohammed. I want to know the CKD and heart disease. These two are always in relation. But what is the DALI? DALI means disproportionate
Your disability adjusted life year.
this lifetime. Age.
Danny? So we have seen that the Danny, you can see this stop. Can you get back the slides, please? So this is the Danny combined, age-adjusted Danny of chronic kidney disease and coronary artery disease combined. In the Southeast Asia, you can take the Danny is around 750 over here and 500, almost 1200 life years lost per 1 million population. That is the combined effect.
Thank you
Thank you
very much.
Thank you.
Thank you very much, Dr. Sengupta. I would like to invite Dr. Mamata Dotto to felicitate